Thank you. We have designed this course on a situation, the edema of optic disc, which is not very uncommon situation in our routine practice. And
there
in the case of this situation why we have designed this course, and it is a practical oriented course, and we have got very experienced speakers in this course. I will be talking about how to differentiate between a true and a pseudo disc edema. After me, we have a talk on unilateral disc edema by Dr. Virendra from Delhi Prasad AIOC, followed by Dr. Satyakarna, and he doesn't give any introduction. Then we have a talk on lateral edema by Dr. Ramesh, and then we have interesting cases by Dr. Preeti, and Dr. Rashmi will discuss the cases. So we'll start with the first talk. At the outset, let me emphasize what is a normal optic disc. A normal optic disc has well-defined margins. It has a thin neuroretinal rim, and importantly, the nerve fiber layer is transparent. The nerve fiber layer is transparent, and in majority of individuals, majority of normal individuals, one can see this like this. A true optic disc edema is a result of axonal swelling. It is basically axoplasmic stasis which leads to this edema. If the underlying process is raised intracranial pressure, it is called lateral edema. Whereas, but if I show you something like this, then we have to put a reasoning process. The reasoning process to differentiate true edema from pseudo edema. Symptoms, and it also includes science and investigations, but in this talk I am confining to the science of this reasoning. This examination is taught in relation with glaucomatous optic disc, and we think that the template is applicable only to glaucoma, but that's not true. It's a template which is applicable to any optic neuropathy, and I'll show you how this helps us even to distinguish a true edema from a pseudo edema. So the first step of the template is look at size, shape, and margin of the disc. You don't pay much attention to this, but in optic disc edema, you have a blurred or ill-defined margin of the optic disc. The next thing is to look at the neuroretinal disc. Look at this disc. This is a failed, this edematous disc, the neuroretinal disc is failed, so this is classically called a pallid optic disc edema. Then we come to the surface of the optic disc. We look at the optic disc hemorrhages. Alongside hemorrhages, those are on the surface, we should also look for hard exudates and pulsations of the vessels. Both these images have nerve fiber layer hemorrhages. But this hemorrhage is in the presence of an optic disc notch and a nerve fiber layer. This becomes glaucoma, and this is accompanying a swollen optic disc which has a different name. And this disc has hard exudates. The next thing is to look at the nerve fiber layer. The nerve fiber layer doesn't mean one should look only for the defects in the RNFS. It can also mean edema or swelling. This is very early disc edema. This is axoplasmic stasis at the core. This is very early disc edema. It can also mean pattern lines which you will see in resolved sample edema. So this is the template. And if we use this template, we can differentiate true edema from pseudo edema. Let us look at these photographs. These photographs are from a 46-year-old lady who complained of chronic headaches for past several months. Her vision was 20/20, color vision was normal, but the discs are swollen. We cannot see the disc margin first. If we look at the vessels, because there is swelling of the nerve fiber layer, we cannot trace the vessels. The vessels are obscure, we cannot trace them through the disc margin. Okay, there are hemorrhages. Okay, there are no hard exudates, but there are hemorrhages. Look at the veins are dilated. So these are all signs of true disc edema. And the neuroretinal rim is fortunately thin, that indicates that this is a relatively recent onset. In contrast to this patient has a long-standing papilledema, and we see that the neuroretinal rim here is weak. In addition to all other signs, this pallor of the neuroretinal rim indicates that this is a long-standing true edema of the disc. And if you take a closer look at this disc, you will see these deposits. These are long-standing deposits. These are also called pseudolucent of the optic disc. This is another example of bilateral disc edema. This is true disc edema, and Dr. Satyakarna will tell you whether this is bilateral papilledema or bilateral disc edema which is not papilledema. Let us look at this disc. This early edema is one which can be easily missed. Okay, this early edema. Now compare this disc with this. This is angry looking. The veins are dilated. And look at the nerve fiber layer. The nerve fiber layer is edematic. This is opaque nerve fiber layer. This is not transparent. This nerve fiber layer is transparent, whereas this is opaque, and this is obscuring the small vessel. Because this is in early stage, the small vessels are obscured, larger ones we can trace. So these signs indicate that this is true optic disc edema. This is another classic picture of neuroretinitis. I show you two similar looking discs. Both the discs are swollen. Look at the nerve fiber there, it is elevated. Okay, one may think that this is true edema. Show you another comparative image. Look at this. Even this is a swollen disc. What's the difference? The difference is in the nerve fiber layer. This nerve fiber layer is opaque, and this nerve fiber layer is transparent. Okay, what we see here, temporal pallor, is a photographic artifact. This disc was a normal disc. This is a small disc which is inserted at an oblique angle. That's why the nerve fiber layer has to climb to the disc. But it is transparent nerve fiber layer. We can beautifully trace all the vessels. The veins are of normal caliber. There are no exudates, there are no hemorrhages. So this is pseudo-papilledema. And this is a true papilledema. This is a true disc edema. This was papilledema. Now look at this. This is also a grossly swollen disc. Now we put the template. Disc margin is well defined. Neuroretinal rim is free. But we can trace all the vessels. Nerve fiber layer is elevated, but it is transparent. We can trace all the vessels. Veins are of normal caliber. There are no exudates. There are no hemorrhages. So this is pseudo-papilledema. This patient had optic disc drusen, which was confirmed on the scan. So if we don't put the template and just look at the swollen optic disc, we may carry it away and say that this is true disc edema. These are another typical examples of pseudo-disc edema, which are often classified as true disc edema. This is disc at risk. It's a small crowded disc which is more prone for developing ischemic optic neuropathy. Because it's a small disc, the nerve fiber layer has to climb up to the disc. It is crowded, and it may give an impression that it is disc edema, but that is not. Similar features are seen in hyperopic disc. This patient has myelinated nerve fibers, and again can be mistaken for a true disc edema. That is not. In addition to that, interestingly, this was a young patient and also had temporal pallor of the optic disc. Actually, this patient had primary optic atrophy. This is another example of a disc edema. But you see something here in the macula. This is hypotonic maculopathy. This patient had glaucoma surgery in the past, and there was low filtering blood that has resulted in hypotony. This is disc edema. Axoplasmic stasis because of ocular hypotony. The clue is the maculopathy. But again, this is edema because of hypotony, not because of raised intraocular pressure. So this table tells us the distinction what I showed you earlier. The important features of this distinction are opacity of the nerve fiber layer, obscuration of the vessels, presence of hemorrhages, hard exudates, and absence of spontaneous venous pulsation in case of true disc edema. If the intracranial pressure is raised, the venous pulsations they will disappear if there is raised intracranial pressure. If you have seen the patient in the earlier stage when disc and the pulsations were present on the disc and later on they disappeared, it is strongly indicative of raised intracranial function. So all these features will help you in arriving at a correct diagnosis when you arrive at this stage of this stage.
Sometimes we try to elicit venous pulsations.
Yes.
If we cannot elicit them by pressing gently, very, very early.
It may mean it's a very subjective test, but it's an important test.
So if we can elicit it, can we rule it out? It's not
depends
best.
on, the same thing is applicable when we do gonioscopy. When you do gonioscopy and you see an occludable angle, we try to judge what amount of force you need to indent open the angle.
Right.
The same thing, it is subjective, but it is an important thing that you can try to assess what amount of pressure you need to indent on the sclera. If it is minimal or moderate, then it may mean that ICT is normal. If it is very severe, it may not. So actually we have to club in this with other symptoms and signs of the patient.
Are the nerve fibers transparent? Or you said that in raised intracranial pressure, the axoplasmic stasis and loss of transparency.
Yes.
What about
They are
cottony?
neither transparent, they are neither opaque. Yeah, it is in between transparency and opacity. There is axoplasmic stasis, but when axoplasmic stasis is because of raised intracranial pressure, when the pressure is raised behind the lamina creplosa, the opacity is much more than what we see.
Then because of
the mechanism is same, axoplasmic stasis, but when it is because of hypotony, it is not as
Amount is
prominent.
less.
Yeah, amount is less. It's not as prominent.
Thank you.
Move on to the next one. After the
Which are very irregular.
Yeah.
Absolutely irregular. They have no pattern, they're just very irregular. And that confirms that it is maculopathy due to hypotony. The disc edema is just associated with that.
Which part of the OCT? The RP layer is, or
The
all
entire
of
thing.
it? Entire thing
The
is
entire thing at the macula.
like a choreograph.
So in a looked up literature for OCT for all kinds of macular folds, and there was a study there, and there was very clear.
So that we will be
picture.
able to see also, wouldn't we?
You would see, but if you think like the picture he showed, everything is radially towards the fovea.
Thanks for giving us this interesting instruction course, and Dr. Nikhil for giving me this interesting talk. There are no financial disclosures. I'll be speaking on unilateral disc edema. And before we go into the talk proper, just a small slide about why do we use the term disc edema and not papillary edema. As you will see in the instruction course at most of the places here, with or without an increase in the raised ICT, increased intracranial pressure. So therefore, unless until it is proven, it may be better to use the term disc edema rather than papillary edema, and we may not be wrong even if it's a raised ICT to use the term disc edema. So what is the pathophysiology? The pathophysiology in patients where there is not a raised ICT is slightly different. So if you look at the ultrastructure diagram of the optic nerve head, we see all the optic nerve fibers, they are coming out at the optic nerve head, and within them there is the exoplasm. There is an active process through which the exoplasmic fluid is passing from the retinal side towards the lateral genicular body, and it is surrounded by the outside the eyeball. The optic nerve is surrounded by the sheath which contains the CSF. So if there is a raised ICT, that will compress the optic nerve. By compressing the optic nerve, there will be a compression of the exoplasmic flow, and there is a resultant disc edema. But in the cases where there is not a raised ICT, in those cases, this exoplasmic flow itself gets stopped because of the active process gets dysregulated. For example, in ischemia, there is a lesser ATP generation, and then in those cases there will be a edema because of the swelling of the axons themselves, and there may be added factors. So these are the two mechanical and the vascular theories of disc edema genesis. Now before we come to unilateral disc edema, just a small slide telling that if you see a patient with a true disc edema in both the eyes, the first thing which we think is that there is something going wrong in the brain, in the CNS. There may be a tumor, there may be a raised ICT, there may be a possible sinus thrombosis, or there may be a transverse sinus stenosis, and we generally think of doing a neuroimaging. But sometimes we may think of systemic conditions. I think this will be alluded to in little detail in the talk by Dr. Satyakarna. but a case of hypertensive retinopathy. On the contrary, when we see a patient with unilateral disc edema, raised ICT, diffuse venous processes and systemic diseases are less likely. And we are more likely to have etiology which could be a local optic nerve or intraocular pathology. Or it could be orbital or rarely a systemic disease that can be manifesting unilaterally. So if we look at these, we can subclassify those into 4 major categories. One can be optic nerve diseases or optic neuropathies. The intraocular inflammation which may lead to unilateral disc edema. Sometimes it can be pseudodisc edema which has been very well covered by Dr. Mukhi. And there can be asymmetric manifestation of a bilateral disease in some cases. So we'll be concentrating mainly on optic neuropathies and we'll discuss the others in brief. The 4 major optic neuropathies that are likely to cause unilateral disc edema are papillitis, ischemic optic neuropathy, neuroretinitis, and a compressive optic neuropathy. We'll begin with papillitis. The papillitis is actually one of the forms of optic neuritis, which includes both inflammation of the optic nerve head, which is called papillitis, or if it is behind the optic nerve, it is called as retrobulbar neuritis. This is a typical example of a patient with papillitis. You see in this picture on the right side of the screen, you can see that there is presence of disc edema, which is actually mild, but there is a drain of the palpebral nerve fibrillate throughout. There is a disc hyperemia as compared to the other side. So this is a patient with a unilateral papillitis. If you see this picture from some of those which were shown by Dr. Nikhil in the last presentation, something like this, what we can find is that in papillitis, the disc edema is only mild. There may be a mild vitritis. The vascular toxicity is not so much, and there are no signs of chronicity or maybe heart exudates, such as the signs of vascular leakage. As compared to this picture, which is a patient with a true disc edema due to raised ICT. So you can see the presence of the deposits, hemorrhages, there is diffuse hyperemia with microtelangiectasis over the disc. However, this may be the case in the established papilledema, and it will be very easy to distinguish and say that this is not likely to be papillitis. But in an early case, there may be a little difficulty, but you may still get some other signs. So, in those cases, we rely on the clinical profile of the patient also. So, in these cases, if you see, in patients with papillitis, usually there is a profound loss of the vision, and it's an acute onset. On the contrary, papilledema patients, they usually complain of transient obscurations of vision, and it's usually an insidious onset condition. In addition, there may be other signs such as oculomotor paralysis, cranial nerve paralysis, loss of corneal sensations. And we alluded to these things that this edema is mild, may show vitritis in papillitis, whereas these are absent in patients with papilledema. And color vision is usually impaired in these patients. The exact pathogenesis of papillitis is usually a demyelinative process, which usually damages the myelin sheath, and thus there is a decrease in the conduction process. We know that in the case of myelinating fibers, it's a solitary conduction which is fast, whereas when there is a demyelination at a particular area, the conduction stops over there. And as a result, it leads to profound visual impairment. The pathology in patients with optic neuritis can be an isolated disease or could be associated with some CNS or systemic disease such as multiple sclerosis. Sometimes, especially in the young children, it can be parainfectious in post-vaccinal. So clinical profile of the patient showing a positive history of vaccination followed by this, or a history of fever followed by a decrease in the vision and disc edema, we should start thinking of possibly papillitis. Ancillary tests can help us. For example, visual fields. It may show a generalized reduction of sensitivity, which is the most common pattern, or sometimes there may be only a small paracentral scotomas which may be seen. But if we look at the literature, all kinds of visual field defects are possible in patients with papillitis. The diagnosis can further be helped by the VEP. The pattern VEP in these patients will show a reduction in the amplitude, but more importantly, it will show a prolongation of the P100 implicit time. What it means is that from the baseline, from the beginning till the peak of the P100 implicit time, the time that it takes is usually about 100 to 110 milliseconds. The standard deviation set for most machines is around 120 milliseconds. So if you see that this is more than 120 milliseconds, then it's highly suggestive of prolongation of P100 implicit time, and it is more suggestive of demyelination as a etiology than any other. We can do imaging, which will show a presence of a typical enhancement of the optic nerve on a contrast image, more likely to be picked up on a contrast image. And there may also be CNS changes in these patients. For example, there may be degenerative plaques, especially in the periventricular area. And what is classically described is that there may be a radial orientation of these in the periventricular area, which is called as Dawson's fingers. So we'll stop on papillitis here, like how to diagnose it. We'll come to the next optic neuropathy, which is quite common, and this for non-arthritic ischemic optic neuropathy. This is again one of the very common cause of unilateral disc edema, which we see in middle-aged and elderly patients. If you see this kind of disc edema, this is different from what we saw before. You see, there is presence of disc edema, but the superior part of the disc is more edematous, and this is appearing very pale. So this is classically called as a pallid disc edema, which Dr. Nikhil also showed in one of his pictures. But sometimes it may not be classical, especially in the early stages. You may see a diffuse edema, the pallor may not have set in, and there may be presence of attenuation of blood vessels, and there may be presence of splinter hemorrhages along the disc. So these findings, which are suggestive of diffuse or segmental disc edema along with vascular attenuation, and maybe in very severe cases spreading to the peripheral nerve fiber layer and maybe hard exudate deposition, are highly suggestive of a possible ischemic etiology as the cause of the disc edema. So in these cases, it is basically the occlusion of the posterior ciliary arteries that leads to the ischemia. It deals in the axonal exoplasmic flow and thus a swelling of the optic nerve head. As I said, it's more common in the middle-aged and the elderly people. There is no gender predilection here, but usually there are some risk factors, and sometimes a patient may not know it, but on your examination, if you send these for BP checkup, blood sugar checkup, coronary artery profile checkup, you may be able to pick up these risk factors. And usually there is a sudden onset decrease in the vision, and sometimes observant patients may say there is a sudden onset visual loss, and there may be sometimes a history of prior similar complaint in the other eye. So the diagnosis is aided by the presence of specific signs, articular attenuation, segmental disc pallor, presence of concomitant changes of hypertensive or diabetic retinopathy, and the other eye examination may also help us. For example, there may be a small disc, which is like in this patient, there is a very small disc, you can hardly make out the top disc at rest. Or sometimes, if the other eye was involved, there may be a diffuse or a segmental disc pallor with attenuated blood vessels. The visual fields are classically called as altitudinal field loss in these patients, which it means that there is a diffuse arcuate scotoma starting from the blind spot and reaching the horizontal. But it's not the only kind of visual field loss we may get. If you see a diffuse swelling, diffuse ischemic process has set in, you may see a complete advanced field loss and a total vision loss. It's common to find in the neuro-ophthalmology clinics patients where we are confused between ischemic optic neuropathy and optic neuritis. Well, with the clinical profile of the patient, like patients being middle-aged and elderly in ischemic optic neuropathy, presence of risk factors such as hypertension, diabetes, coronary artery disease, and the presence of segmental disc edema are more in favor of ischemic optic neuropathy than optic neuritis. Visual fields, if they are typical, they may help us. And you can do a VEP where demyelination will show a prolongation of P-anterior nucleus times, but it may not be picked up on the patients with the ischemic optic. The other kind of unilateral disc edema is seen in neuroretinitis. Some people believe it's a type of optic neuritis, but usually it's a different pathology. There is basically a segmental disc. There is usually a disc edema along with presence of some macular radiating folds of hard exudate. This is a typical pattern. So in these cases, this macular star kind picture which happens is because of the resorption of the fluid, and it leaves presence of the hard exudates in the macular area. And usually the vascular occlusions may be one of the causes of unilateral disc edema. And if you look at the picture, you can hardly have any other differential diagnosis other than having a diffuse CRVO as cause of that disc edema. But sometimes in the patients where it's in early stage, it may be a little difficult. For example, in this patient, it's a patient with an incipient CRVO. The patient shows the presence of disc edema, there are hard exudates, there is presence of hemorrhages diffusely. In these cases, doing a FFA may help in the diagnosis. And this is the enlarged picture of the same patient which shows presence of disc edema along with cottonwool spots and ridges. Another cause of possible unilateral disc edema can be a liver secretory optic neuropathy. And in these patients, why it may be it's actually a mitochondrial disease where it's affecting the nerve function. Usually it's a sequential involvement of the optic nerve. So that is why we see it as a unilateral disc edema more often than in patient than bilateral. But sometimes it can have a bilateral onset. presentation is similar to optic neuritis, but here the visual acuity does not recover well. And if you do a FFA, you can see microtelangiectasis in the very early stages. That may be helpful. Some of the uncommon causes can be intraocular inflammations. For example, in this patient, if you see, there is a disc edema, but it's not the features are not confined only to the nerves. You see the diffuse RP changes over there. And if you see the montage of this patient, you can see presence of subretinal fluid in these areas, suggesting that there is a diffuse inflammatory process going on. We did a B scan for this patient and found a classical T sign. So this was a patient with posterior scleritis causing a unilateral disc edema. I'll just rush through the remaining things because they are less common. But compressive lesions sometimes can have unilateral edema if they are orbital, or it can be asymmetrical involvement in the CNS tumor. But in these patients, the onset may be more insidious. There may be history of trauma. There may be some specific orbital and other signs which may help. For example, in this patient, there is suggestion. There is a little drooping of the eyelid, and this is the enlargement of the same. And we did a reach and found a presence of a cystic lesion with a scolex, and this was actually compressing the optic nerve in this patient, causing the unilateral disc edema. Then in some of the patients, there may be presence of the reduced corneal sensations. Sorry, the video didn't play, I think. And in some patients, there may be presence of motility problems along with a little proptosis that may give us a suggestion that these may be having something else as a form of disc edema. So neuroimaging and orbital imaging is very useful in these patients, and we can pick up patients having tumors close to the orbital apex, and sometimes sinonasal malignancy migrating into the optic nerve apex. Very rarely there may be a mucosal cystic lesion diagnostic causing a unilateral disc edema, and there can also be the presence of traumatic sequelae or myositis. So these are the main things which are the cause of the unilateral disc edema. Very rarely it may be because of some of the CNS causes if it's presenting early, and pseudo disc edema may be one of the causes. And these are the main things which are the cause of unilateral disc edema. A specific approach detailing the history of the patient and a meticulous examination to ancillary findings may help us in the diagnosis. Thank you very much.
Next we have Dr. Satya Khanna. He is a neuro-ophthalmologist trained at Chintamitra and now working in Noida. He is talking on bilateral disc edema, which is now practical.
Covering a lot of the things that I wanted to speak on. Okay. And when I was making this presentation, I realized that bilateral disc edema, even if it is not papillary edema, it can range from benign to fatal conditions. So let's see. This, as we've already seen in the last two presentations, is not with sudden diminution of vision in the right eye 4 months earlier, and the vision was finger counting 1/2 a meter in the right eye and 6 in the left eye, RAPD in the right eye. His fundus examination shows CRVO with CME and optic nerve head. So in this picture you do not see any specific signs of this brucine, but if you look at the next eye, the other eye, then you can see very typical features, lumpy bumpy appearance of optic disc brucine. So I just kept this case because I wanted to show that this patient who had a history of hypertension, his BP was 180 by 130, and when he presented to us it was 160 by 90. All his other tests were normal. Even renal Doppler was normal. So he was a hypertensive. He did have accelerated hypertension, but that led to retinal vein occlusion in one eye. And the risk factor here, the trigger factor was the blood pressure, but the risk factor was the optic disc brucine in both eyes. Presenting to us without any fundus findings would have been just simply congenitally crowded discs, pseudopapillary edema. But in this situation, you have a true disc edema in one eye, as seen on this angiogram, and the other eye had pseudo disc edema. So, of course, this is one rare situation. Now, let us come to another case: a middle-aged male who has vision of 6 by 9 in both eyes, and his BP is 180 by 125. And this kind of a picture, where this, of course, is in retrospect. Let us see what does this kind of blood pressure do. It causes persistent and elevated blood pressure, causes AV nicking, can cause cotton wool spots, retinal hemorrhages, and disc edema, depending upon the amount of blood pressure and the time duration that it has been elevated. Now, with malignant hypertensive retinopathy, this patient who presented to me had mild disc edema, but he had significant cotton wool spots in both fundus, and he had hard exudates in the macula close to the fovea, an incomplete macular star, and the BP was very high. That part, that even this kind of a picture can progress to permanent visual loss. So this is just to show you the importance of not ignoring high blood pressure and hypertensive retinopathy, even in closely for a few months till the disc edema has resolved. Otherwise, it can lead to this situation. This is another picture where you can see that typical signs of true disc edema in both eyes, with hemorrhages, with exudates, with a macular star. And the right eye vision is good because the macula is not involved to that extent, and the left eye, since there are exudates in the fovea, that is the reason for the poor vision. And when the BP gets controlled and the exudates start resolving, the vision starts improving. So it is not the disc edema which causes the visual loss in the acute stage. It is the macular pathology which causes the visual loss. So you can give a good prognosis if the systemic conditions are well controlled subsequently. And you can see the cotton wool spots, which are a hallmark. Bilateral loss of vision. This is another situation where now the difference is the initial presentation with bilateral loss of vision in a 12-year-old child, which is basically a situation of bilateral papillitis. This is of course showing one eye of this patient, and this is another patient with both eyes disc edema, which usually looks symmetrical. It may be mild, moderate, and it is usually associated with headache, sometimes pain on eye movements, and usually it is post-infectious, and it also can be associated post-immunization. And this kind of a situation is very well responsive to steroids, though you have to give a longer course of steroids than the usually recommended ONTT, and that the reason for that is that this is usually steroid dependent. So the moment you taper off the steroids, the vision again starts dropping. So you have to give it for a little longer period, say 6 to 8 weeks, and slowly tapering. They do very well, and they are not associated with MS. So it is mostly infectious, as I said, and or post-immunization. Then this is another situation where you have, this is of course the left eye of the patient with disc edema, and he has these hemorrhages, and you would have other signs of diabetic retinopathy, which could be exudates, urcinates, and even it could be a PDR stage. But now you see this diabetic papillopathy in both eyes, where again you have hemorrhages. You don't have very typical retinopathy in this situation, in this case, but the clinical presentation is of mild or no visual loss, and it is bilateral in 50% of cases. There can be persistent disc edema for many months, and so the important thing is to follow up the patients for many months and keep expecting it to improve. If there is any sign of deterioration, it means it is going into irreversible ischemia. Good visual outcome is usually the prognosis, and most commonly it is seen in young patients with insulin dependent diabetes, and there may be associated diabetic retinopathy, as I said. Then coming to the inflammatory variety, this is a situation where you have bilateral disc edema with the fundus picture is not, it doesn't look like a normal fundus at all. Though of course it is hypopigmented, the skin color also may be so, but when you look at the this situation, the disc edema is not, again it may or may not be associated with visual loss. It is basically secondary to the retinal pathology and the choroidal pathology rather. So this is bilateral. It may lead to loss of vision also, but usually it is painful. There is disc hyperemia with posterior uveitis, and serous retinal detachments may develop later on. There may be anterior uveitis with mutton fat keratic precipitates, and the patient has other symptoms like tinnitus, headache, vitiligo, alopecia, and there is a very significant response to steroids if started on time. So this kind of a situation needs early detection and management by a uveitis specialist. This is another situation of leakage with severe macular edema, and you can see the OCT showing the severity of the macular edema. So the disc edema is not the main pathology here. It is not papilledema. It is related to the choroidal and retinal pathology. Okay, this is a serious situation which presents as an emergency, and patient would have a headache or would have sudden blackout or loss of vision in one eye, sequentially followed by the other eye. He would have picture like this, or it could just be ischemic optic neuropathy in both eyes. It could be a central retinal artery occlusion in both eyes, ocular ischemic syndrome with this one eye already involved. But here you can see that since the right eye has a disc pallor, it must have happened at least a month ago, and the left eye is acute, and it is a pale disc edema. So there is rapid sequential bilateral loss of vision in giant cell arteritis, anterior ischemic optic neuropathy, CRO, ocular ischemic syndrome, all of these in one and then both eyes. It is a pale disc edema. There is usually associated history of headache, jaw claudication, calf pain or fever, and usually elderly with a poor visual prognosis. If you detect it in time in one eye, you should start steroids immediately, and the steroid course has to be prolonged till the ESR comes down to a normal range and stays like that for a few months. The patient would require steroids. Another potentially fatal condition is an infiltrative leukemic optic neuropathy. As you can see here, it's a very severe disc edema, and there are a lot of these infiltrates on the disc. And this kind of picture can be unilateral or bilateral, as in this case. But here what you notice is this is not typically bilateral disc edema without papilledema. This patient has infiltration in the right eye with typical infiltrates, and left eye seems to have papilledema due to raised ICT. So this is a little different picture with visual loss more severe in the right eye. So this clinical situation of sudden loss of vision usually happens due to advanced CNS involvement of leukemic disease. It can happen in other infiltrative conditions. One of the common ones is sarcoidosis, where it may also present as optic neuritis, and it may be associated with vasculitis or conjunctivitis in the retina. Okay. These reports of infectious optic neuropathy have come into literature, and most of the literature presentations are in the last few years. This was not very commonly reported earlier. Now, most of these are from India, by the way. This is a typical picture of HIV optic neuropathy in both eyes with a lot of buttonwool spots. That is the typical feature. And you can see the angiogram which shows the disc edema and shows the ischemic areas around the disc, and a patient who would turn out to be HIV positive. Dengue is another condition which can cause bilateral disc edema, which is not papilledema. Hepatitis vaccination can be followed, and if you treat that with steroids, responds very well. Chikungunya, this is one patient of bilateral chikungunya papillitis. This is again not disc edema, it is anterior, it is inflammatory involvement of the optic disc. Okay, last but not the least, a 25-year-old male who had sudden painless blurring of vision in both eyes with a 6/24 vision in both eyes, and pupils were sluggish. He had central scotomas. Without fundus examination, if the fundus examination was normal, I would think of either it is toxic optic neuropathy or there is some other, tobacco, alcohol, amblyopia. But this was the fundus picture. You had bilateral hyperemic discs with flame-shaped hemorrhages. This could not be explained. It didn't look like bilateral optic neuritis. So we did an angiogram, found nothing in the fundus. It was only a disc edema and with the flame-shaped hemorrhage. This patient, his detailed history was that he had a poor appetite. On examination, he was thinly built, and on testing, he was found to have vitamin B12 deficiency, and hemoglobin was 12. So he also had occasional alcohol and smoking habits. So this patient recovered very well over 3 months with intramuscular and oral multivitamins and improved diet. So basically, he had a nutritional optic neuropathy. So this is just a part of the spectrum of bilateral disease, this kind of situation. The investigations that we do, first and foremost, in all such cases, please check the blood pressure in your OPD routinely. Then visual field analysis is extremely important because it can differentiate anterior ischemic optic neuropathy from papillopathy, papillitis, or nutritional optic neuropathy. Then you have the routine blood investigations, blood counts, sugar, ESR, CRP for AION, B12 levels, depending on the clinical situation. You have, of course, a patient who is clinically has toxic symptoms, then HIV, dengue, hepatitis serology, and angiography for differentiating the diabetic fundus from the hypertensive fundus, and of course giant cell arteritis to confirm choroidal ischemia or severe ischemia of the fundus, and VKH to confirm the choroidopathy. Okay, I don't think OCT has any role in the differential diagnosis of these conditions. That may be useful in follow-up of the disc edema, but otherwise I don't think it has any role, and couldn't find any study either on this. And ultrasound for drusen, as it was shown earlier, CT scan also for drusen, but MRI very important in, say, papillitis, where you want to confirm demyelination, VKH, and where you want to see pachymeningeal inflammation, and then
Thank you, Dr.
that there should be diabetic retinopathy along with it? And also, do the sugars have to have been out of control, or can it occur anyways?
No, I don't think so. That it is invariable that there would be a diabetic retinopathy.
Right. And does it need a history? Suppose he comes and says he's very well controlled over the last 3, 4, 6 months. I mean, is there any relationship? That's what
era where maybe these are the people who are on the edge, and with one more insult from penetration, because they might you relieve the pressure and they not.
Thank you, Rashmin, and thank you, Nikhil, for this opportunity to speak and asking me to speak. And the previous 3 speakers have made my job easier. Basically, I think we need to look at whether it's a true disc edema or a pseudo disc edema. Both can be unilateral or bilateral. And then true disc edema, papillary edema the word does not really matter with tumors, because BICH as well as tumors, these are the 2 things we need to. I do not have any financial disclosure, and the questions an ophthalmologist should be asking is, what's the cause for raised ICP here, whether it's a tumor, BICH, or malignant hypertension, because this is very, very common. Think of common things first and then go into the other things. And how can we help, and how do you monitor, because you need to keep on sending inputs for the neurologist, and how can we prognosticate, especially this is where some of the newer tools can help. And as you know, the cerebral circulation goes from the lateral ventricles and it comes to foramen Monro to the 3rd to 4th ventricle, and it goes anywhere in the root. If there is an obstruction, it can lead to papillary edema. The CSF pressure around the optic nerve increases, and there is orthograde exoplasmic flow, and this leads to disc edema. And there are theories of vasomuscular instability or inflammation or Harris theory. These are the 3 theories, and basically what happens is, along with that, there can be collateral damage. Patient can have ataxia. There can be you need to check for their balance, and they can have ocular motility problem, basically the 6th nerve palsy. And these are the main causes you need to remember. Most commonly is increased brain volume. This is very important due to any kind of occupying lesion. It can be hemorrhage, it can be tumor, it can be just an edema. And sometimes in kids especially it can happen because of decreased skull volume, specifically in craniosynostosis. You can typically see that typical dysmorphism. And choroidal plexus tumors are kind of rare, and there can be decreased CSF drainage. And this is the kind of algorithm, this is where you need to follow. And never forget the malignant hypertension, because this is the simplest test you can do for a bilateral disc edema or papillary edema, and then go into other modalities depending upon the features. And papillary edema features are mostly asymptomatic, or they can have pulsatile tinnitus, especially when they cough or when they change their posture from sitting to bending down. And they can even have transient visual obscuration, and they can have even photopsia. These are all early signs of papillary edema. And diplopia, of course, because of the collateral pressure on the 6th nerve. And the signs are 2. One is mechanical, where all of these have been described by Nikhil very well. Filling of optic disc, anterior extension of nerve head, as well as edema of nerve fiber layer. And there are vascular signs. I think this is also very, very important. Vasculars are mainly venous congestion, papillary or peripapillary hemorrhage, cotton wool spots, basically because of exudation, and hyperemic looking optic nerve head and hard exudates. And this has already been described. How do you differentiate between the two? And always look for, do a quick all the cranial nerve examination. It takes around 30 to 40 seconds to have a gross screening for third cranial nerve, all the cranial nerve, like absence of wrinkles on the right forehead in this case, check for deviated angle, check for quick corneal sensation, because these are all needs to be a part of workup, and also check for abduction lag. Never forget to do an ocular motility evaluation in these patients, and this is a part of comprehensive evaluation of these patients. And as we discussed earlier, this is where spontaneous venous pulsation can be shown, and sometimes, as Madam asked, that we can use the middle finger to just touch the globe of the eyeball, so that you have 90D and the middle finger you can just press. And there is an article in BJO where you can say that 33% of them can still have a tumor. It's not that it's a sine qua non that if you see it, they won't have it. So I would give a reference for that article. You can go through it later. And these are the stages where there is early papilledema, where Nikhil described very nicely. And this is established, where the disc edema is very proper. And this is what is called champagne cork appearance, where there is chronic. And atrophic is very important because they will have one or two subtle signs of disc edema, but the main thing is they have pallor. And this is what Dr. Satyakana showed, the humpy, bumpy kind of disc. This is a patient with retinitis pigmentosa. You can see the RP changes. And on fluorescence, this is again a simple test you can do to demonstrate this disc drusen. And one important thing, it's important. This is again a disc drusen where you can see a humpy, dumpy kind of appearance. One of the important things, if you see a patient or a child with this, you need to give them a note saying that don't image them. This is the normal finding, because neurologist patients. But this important note to the neurologist is very important, because whenever they check, they keep on doing MRI scan. And this is again another picture of the same. And the B scan is again a simple tool where you can see this classical calcification there, high big. This is from all the gains you will see this classical image of this disc drusen. Investigation. This is the routine investigation. What I would add is the color vision sometimes. And this is the kind of nomogram, and MRI is preferred imaging modality, but especially to prognosticate or follow, may not be so much for diagnosis, especially in a small kid with BICH, you may not have accurate finding. So maybe it's useful to get it, but it's not a must for basic clinical evaluation. And this is a picture of hypertensive retinopathy. And MRI is a must for all these patients. Once you have found out, you do a cranial examination, you do a ocular motility, you do a disc evaluation, and then come to a diagnosis that it's papilledema. Then you have two parts, whether it's because of tumor or it's because of idiopathic intracranial hypertension. So you do imaging, it's quite obvious. Most of the times you will get wherever the tumor is, either it is in CP angle like this, or it can be at chiasma. Chiasmal tumors rarely lead to disc edema. And this is classical tumors. And sometimes we can have this is a question. Most of the patients, if you don't suspect the tumor, like you do check for ataxia, you don't see any ataxia or things like that. If your diagnosis is more towards BICH, I would say that get MRI and MRV at the same setting. This is the question or dilemma most of us will have, whether to go which diagnose, because you need to prioritize. You need to go for one which is the best. So it's best to get MRI and MRV together if your index of suspicion for BICH is very high. This is another mistake. Most of the patients which are referred, they have a complete CSF analysis, but unfortunately, they don't have lumbar puncture CSF opening pressure, which is most important than anything else. We also need CSF analysis because we need to rule out other causes. But the most important investigation, I would say, is opening pressure. You need to keep on writing it when you refer to the neurologist. And BACH management is both surgical as well as medical. This is one of the cases I would like to show you. Typically, this child has around pubertal or post-pubertal age, comes with this headache and diplopia. You can see an obvious bilateral abduction limitation with typical esopropia in primary position. She had bilateral 6-nerve palsy. Along with that, she has disc edema. You can see that it's very subtle. It's not very florid edema, but you can see the blurred disc margins and retinal nerve fiber layers are edematous here, both the disc. And this is the enlarged view where you can see it much clearly, where left eye is much more than the right eye. And MRV was kind of normal, and probably we could not really say what is the reason for her case. We put it as idiopathic, but these are, whatever are there in yellow, I think they are the most common kind of precipitating factors if the person is not obese. There are two categories again in BICH: obese patients, non-obese. Or in pediatrics, it's a little different. I will show you that pediatric versus adults. CSF opening pressure is not very high in kids. It can be very high in adults. Less associated with obesity. Basically, they have two groups: pre-pubertal as well as post-pubertal. And papilledema is sometimes can be absent in very young kids, and it's always present in adults. And this is the first drug of choice, acetazolamide, which responds very well in the early stages. But we do have cases coming with different stages. It depends upon what stage they come. And steroids are indicated in these kind of cases along with tablet acetazolamide, especially when there is sudden loss of vision in the presence of inflammation. You can even add. Otherwise, this per se can be a causal association for BICH, because some of the neurologists just give steroids which may not be appropriate in this kind of situations. And then role of repeated lumbar puncture is not very well known. And you have, I would not go into the, and this is the cartoon showing how do you do this optic nerve fenestration. Most of the times it is the ophthalmologist who should be doing, either neuro-ophthalmologist or oculoplasty surgeons can perform this. And there is almost 1/4 of the patients can have recurrence, because BICH can be a recurrent disease sometimes. And this is that kid where you can see that completely after acetazolamide, you can see that the esopropia is gone, abduction has improved completely, and you can see the pre-medication disc picture, and this is the post-medication picture, which is completely resolved with. It was associated with hormonal change in that kid. Probably that's the reason why she got. Edema is a sign of systemic disease. Rule out ocular disease as well as malignant hypertension. As an ophthalmologist, this is kind of pretty easy for us to rule out. And image, and it's a transdisciplinary approach, and it can be life-saving. Thank you so much. Within 4 to 6 weeks, the child resolved. But you need to keep on observing that. Like, do a Humphrey's visual field test if possible. In kids, sometimes it's not possible. In pediatric age group, flatness of disc is the kind of endpoint. But in adults, we can take parameters of HVF as well as clinical photographs as well as maybe OCT. So it's kind of quite variable. We need to have follow-up and then decide over a period of time which category they need. So ideally, I would say 2 to 3 months of medication, and then we can go into that. And for example, if a patient comes with established papilledema, with the vision is already compromised, they have a very huge field loss. Generally accepted, it's a debatable talk, where generally acceptable thing is that whenever there is more of optic nerve involvement, things like that, then do be more. Like if a patient has sinus venous thrombosis, they need to have the medication for that, and then we may have to wait for a longer period of time, because if you inside, they can have a lot of bleeding also, because they are
Ramesh, do you use a commercially available manometer or you just
had so much time because it's the best thing that you don't do that. You do it yourself. That's the best thing. But I send it to neurologist.
Again, there's one more this thing, paradoxical thing is that steroids themselves can cause idiopathic intracranial hypertension.
Right. That's why specifically I said don't use it as a primary line of treatment. Whenever the vision loss is very significant, there is early disc edema, along with acetazolamide, start steroids.
Normally neurologists start furosemide in addition to acetazolamide.
Yes. If patient cannot tolerate acetazolamide, furosemide is a very good alternative. And some people...
No, and steroid in fact can increase the more than people who are not put on steroids and just on acetazolamide. So steroid is reserved only for a very fulminant, acute cases where you are just waiting for surgery.
The role of steroids for AIOC?
Controversial, not proven. Only person who really wholeheartedly believes in it is Dr. Hedek. So non-arthritic, we are talking about non-arthritic anti-ischemic optic neuropathy. The general consensus is patient comes to you in first 48 hours. Maybe there is a role of steroids. Arthritic AIOC, definitely steroid has to be given immediately and has to be continued till ESR comes back to normal, because there you are giving it to preserve the vision in the other eye. In non-arthritic AIOC, if the patient comes, let's say within first week, and
heart pumping is less or something like that, which is again precipitating the
not that
I will put it this way, that if there are no clinical, when there is no clinical history and no evidence of diabetes, hypertension, then you should investigate the angle of this. Literature says carotid artery disease is not directly related to ischemic optic neuropathy, but I've seen so many patients. That's why I think carotid Doppler ultrasound is a must. If you don't have the cause, clear cause like diabetes or hypertension, and cardiac workup. So these two things are to be done.
Because I have seen one or two patients who went for angioplasty and everything became all right. In such cases, I just evaluate their heart every time.
A word about the disc edema. In papilledema versus the other conditions like ischemic optic neuropathy and papillitis, in most of those situations it resolves in 4 to 6 weeks. Okay, so either it will improve, become normal, or it will end up with disc pallor, and the clinical visual assessment may or may not be normal or abnormal. But in case of papilledema, it may persist for months or even years. So you may be giving the right treatment. The neurologist might say that the intracranial pressure has been checked and it is normal, but the disc edema might still persist. So don't take it easy. Keep doing the visual fields and the visual assessment, and don't do any other intervention. It is normal, vision is okay, but disc edema is not going. They get frustrated, you get frustrated. You're still giving them a lot of Diamox. They've got side effects.
What about obstructive sleep apnea? I've found increasingly a role of obstructive sleep apnea, not only in children, but definitely in adults.
Yes.
So do you specifically ask about that?
Yes, so my normogram for a patient who has non-arthritic AIOC.
Pain.
Yeah, I would say it's unusual, but not so much, because it's quite variable. The disc edema severity is not directly proportional to the amount of CSF opening pressure or CSF pressure. But maybe kind of little bit unusual, but it's not directly proportional always.
Another issue is size of the optic disc.
Right.
Size of the optic disc
This lag, yes.
which is common in our population, and disc edema
Probably means the pressure is quite raised.
Yes.
But what we're finding is that there's a group of children in whom, if you look at the MRI, there's a shift down of the cervicomedullary junction before you get really high pressures, like in the 40s of centimeters of water. So I think the anatomy of the cervicomedullary junction also plays a role in how they present, which is why I really liked your case, because that's the sort of case that we see where we specifically ask the neuroradiologist, is that cervicomedullary junction, or are the tonsils a little bit low of the cerebellum? And I wondered if the panel as a group have noticed that, or can make any comments on that.
Is what is highly underestimated is weight loss, and it's very commonly forgotten. Many of these adults are obese, And there are studies which have shown that up to 10 to 15% of weight loss can actually completely cure the disease even without pharmacological therapy. So that's one point we really should emphasize. The case of a 47-year-old male who comes to us with sudden painless blurring of vision in the right eye for about 20 days. There's no other history. I'm just going to fairly quickly run through the cases so maybe Dr. Ashwin can also have comments. His best corrected visual acuity in the right eye is 2400, the left eye is 2030. He does not remember any episodes of having lost vision in the left eye and basically has no complaints with the left eye. He had a relative afferent pupillary defect, ocular motility was fine, color vision was defective in both the eyes and the anterior segment was normal. Now this is the fundus exam. So here we can see from what we've gone over so far that this really is dyschedema. There's a grain of the nerve fiber layer here. You can see the venous tortuosity. So this is basically dyschedema in the right eye. And now let's look at the left eye. So the left eye is not really normal either. We can see clearly that this disc is pale and there's not really much of a cup if we try to look for one. So at this point...
So I would just like to stop here and say that with this kind of history, what would you tell the audience, this process of dyschedema, is it from the optic nerve, is it from the eye or...
More than the brain, the dyschedema is not that severe like we were discussing before. It's more of a clue. This typically has been described as a Foster Kennedy or a pseudo Foster Kennedy. That's what this is called, where we have a swollen disc in one eye and a pain disc in the other. Now the point here is we decide whether it's true Foster Kennedy or pseudo Foster Kennedy, and there will be certain clues to that. The primary clue will be that the swollen eye, that's the disc with the eye with the swollen disc, has vision loss. It's 2400, which means it's not papilledema or dyschedema because of raised ST, it's because there is a neuropathy that's causing this. So at this point, we went ahead and did the visual fields. The visual fields here in the right eye, here you can see that there's more of an inferior quadrantic defect. The left eye also shows this kind of inferior defect, which here almost looks like an inferior attitudinal. And so what next? Would you image? Was the question.
Yes. Maybe we'll open it up to the audience first as to, do you think we should go for neuroimaging in this patient?
How many of you would you like to image this patient?
Right, it is respecting here, true.
But the other eye is not.
Yeah, the other eye isn't. So respecting the vertical.
The patient data, the visual acuity and color vision.
Yeah, and the history. Left eye had no cup and is pale, and he hadn't noticed yet. Probably had a previous episode. Anyway, so we made a provisional diagnosis of AIOC in the right eye, and like I discussed, vascular risk factors. It made our life a little easier because the patient came in with a CT scan done by the physician elsewhere. So we were just playing safe there, I suppose. And on systemic evaluation, we did find that he had hyperhomocystinemia and hypercholesterolemia. This is just the point I wanted to make, which Dr. Rashmi just made a while ago. We're seeing a large number of young patients with NAION where it appears that homocysteine is the single factor responsible. We're seeing that fairly often, and that the edema is fairly resolved, almost resolved here. So that's the other thing about NAION dyschedema, it usually does resolve in 6 to 8 weeks. If this was true papilledema, may not have resolved.
The interesting thing I've noted is that when the second eye usually follows the visual outcome of the first eye. So if first eye recovers to 6/6, usually the second eye also recovers.
With history of decrease, painless and gradual over the last year, as she said. Again, no pain, no trauma, no headaches, no non-systemic illnesses. Her visual acuity in the right eye was 20/20 parts. Left eye was no perception of light. She had a relative afferent pupillary defect, of course, in the left eye. The right eye color vision was marginally decreased. The anterior segment was normal. And this is how she looked. So remember, she's come to us with history of vision loss in the left eye. So this is the left eye. The left eye shows a pale disc. And now the right eye is swollen again. And so like we were discussing before, this is true Foster Kennedy syndrome. This is where, sorry?
How do you know?
So the right eye has, she comes to us. Correct.
And not allow an edema and cause raised intracranial pressure.
And the most important issue is gradually progressive loss of vision. This is an acute drop in vision. Can happen even in tumor, but
So the history and the fact that, again I'm stressing on the fact that the eye and the gradual painless decrease in vision would push us towards imaging in this patient. So we did do a Humphrey visual field, extremely unreliable, didn't show any pattern. And this is the imaging. So she basically had a fairly large tumor extending from the clivus anteriorly, and it had, this is not a great picture, it had encased the left nerve, it was extending towards the right and causing pressure on the right as well. This is another axial scan here, perilesional edema here. It's a fairly large tumor. It turned out to be a meningioma, and they needed surgery.
These two pictures show the importance of always doing an MRI of the brain with contrast. If this picture had contrast in it, this lesion would have become very, very hyper intense.
So just to summarize what we unilateral disc edema with the brain disc in the other eye, these are all the possible differentials, and we should take a careful look at the history and visual acuity to give us the clue. So we'll go on to the next case. So this is a 9-year-old boy who basically came to us with history of double vision for the last 4 days, and he had this picture here. You can see the esotropia, and the ocular motility was normal. Couldn't really find any deficits. And this is his fundus picture. So we have a 9-year-old who comes to us with fairly good vision, complaining of double vision with esotropia, with this kind of a picture. So how many of you would go ahead and image?
Again, there should have been all hands up. Bilateral disc edema is an emergency. Please do an MRI imaging.
Imaging was reported as normal. So the MRI brain and the MRV was normal. Again, here the point I wanted to make was, if we look carefully, this is a normal MRI, but it will give us some clues. So let's look a little bit at this area, and you can see here that there's a flattening of the globe. You can see that there's increased CSF. You can even see that here. There's an increased quantity of CSF around the nerve. So there is no space-occupying lesion, but these are clues which push you towards the other diagnosis, which is IIH. So we went ahead and did an opening pressure, which was 40 centimeters, which is fairly high for his age, and reached the diagnosis of IIH. This is another interesting finding. He came to us a couple of hours after the LP was done, and the esotropia was completely gone. So this does happen fairly often. Even with the single LP, it's enough to relieve the 6th nerve of his pressure, and the EP goes away. So we did investigate them systematically. This is important to do in children. There are many treatable, preventable causes of IIH, especially in prepubertal children. He was found to have vitamin D deficiency, started on treatment for that with our pediatrician, and started on astazolamide. This is 2 months later.
Okay, and this is totally neutral competition. There is no biases will be there. That's why we have chosen the judges at the last minute. Even the judges do not know that they are going to judge. That is the beauty of the competition. And to judge, Dr. Giridhar, Dr. Krishna Prasad, and Dr. Saha are there on the front rows. Okay. So even if you know them, you have not met in this regard. And to co-chair with me, Dr. Amit Koshla, and originality, there will be 25 marks for that. Content and relevance of the, then it makes no difference. Okay? Can we call the first?
We started Dr. Fatima Benazir. She is speaking on outcomes of deep anterior lamellar keratoplasty by big bubble technique 2 years after testing.
The study is outcomes of deep anterior lamellar keratoplasty by big bubble technique. As you all know, keratoplasty has been the gold standard for treating corneal blindness, but there are certain disadvantages attached to it, like risk of endothelial rejection, post-op recovery is lower, and need long-term steroid application. Now that is a newer variant where we remove the diseased anterior layers of the cornea and retain the healthy innermost layer. Here, there is no risk of endothelial graft rejection. Donor cornea tissue selection is less stringent, and if the graft fails, we can always go in for a repeat penetrating keratoplasty. with inability to obtain a smooth surface, leading on to a poor quality of vision. The deepest and most desirable plane is obtained by big bubble by Anwar. Here, air is injected into the stroma with a 27 gauge which forms a big bubble between the decimal membrane and the stroma, leading onto a clean cleavage line that aid in dissection. Excuse me, the video is not. Inclusion criteria was keratoconus and patients with anterior stromal pathologies like macula and granular corneal dystrophy, anterior stromal scars. Exclusion criteria was patient who had intraoperative perforation and had to be converted to penetrating keratoplasty, less than 6 months follow-up endothelial dysfunction, and diseases like glaucoma, amblyopia and retinal diseases. Pre-op evaluation included uncorrected and best corrected visual acuity, manifest refraction, slit-lamp biomicroscopy, tonometry, dilated fundoscopy. 16 eyes of 15 consecutive patients were taken up, and all the surgeries were performed by a single surgeon. The center of the cornea is marked, and after partial trepanation, the air bubble is injected. The superficial layers are removed, and you can see the clear endothelium beneath it. The endothelium from the donor tissue is removed and secured onto the stromal bed with 10-0 nylon 16 interrupted sutures. The selective suture removal was started at 3 months after the surgery based on the corneal topography. Outcome measures were uncorrected and best corrected visual acuity, post-op endothelial count, intra and post-op complication, surgically induced astigmatism. Follow-up was at first day, first week, 1 month, 4 months, 6 months and 1 year. Analysis was done by SPSS statistical software. Sex distribution, male and females were equally distributed. Age group of the patient was more mainly from the 20 to 30 age group. Left eye was more predominantly involved, and the donor tissue came from the 60 to 70 group. The quality of tissue was mostly good, and preservation time ranged from 16 to 92 hours. Indication of the surgery was keratoconus. A major indication was keratoconus. The mean pre-op visual acuity at the start was 1.627, and the visual acuity at 1 year was 0.376, and the difference between the two was statistically significant. The mean spherical equivalent at the end of the study was 2.9, mean astigmatism was 3.8. Complication encountered were double anterior chamber, shallow anterior chamber, both resolved with conservative management. Steroid-induced IOP rise in 5 patients, which also resolved with topical anti-glaucoma medication. Graft failure in 1 patient, interface A's in 4, loose sutures in 2. The average endothelial count at the end of the study was 2,343. Visual acuity of 20/40 or better was seen in 63.75% of cases. Visual acuity of 20/20 or better in 12.5% of patients, which is comparable to the Anwar et al. Study. 3 patients had vision less than 6/18, of which 1 had graft failure and 2 had interface haze. 6 patients had microperforation, of which 1 went on to have graft rejection and 1 had a visual acuity of 6/24. Others were better. Visual acuity in patients who had achieved big bubble was 0.2886, and visual acuity in patients without big bubble was 0.639, and the difference was statistically significant. We found that the mean postoperative cylindrical refractive error and mean spherical equivalent in our study was comparable to the other similar studies. Big bubble was achieved in 75% of cases, which is also comparable. Limitation of our study was a small sample size, short follow period, and inability to record the pre-op endothelial count. So the interpretation from this study is a dark by big bubble technique is a valuable treatment in anterior corneal pathologies. The visual outcome here is good when exposure of bismuth membrane was achieved with big bubble. But because of advantages of dark in elimination of endothelial graft rejection, less stringent follow-up care, better utilization of tissues, it can be considered as a first surgical option in patients with keratoconus, corneal stromal pathologies with normal endothelium. Thank you. A patient who RGP lens or Bosque lens, and and who didn't have any endothelial scar.
So wouldn't you give an option of 7 to 6 years in these patients for?
Definitely, sir. If it's a progressive disease, then see, 3 are non-progressive patients with no endothelial scarring.
And when you label a patient as non-progressive, how many
Patients were selected, they were confirmed to be a non-progressive patient and then selected for that.
Please correct yourself.
Report for human corneal endothelial cells. The objectives to be achieved were divided into 3 key steps. First, to accomplish the denudation of amniotic membrane. Second, to standardize the isolation of corneal endothelial cells. And third, to use this denuded amniotic membrane as a scaffold for the isolated endothelial cells. In the first step, the amniotic